So one question for me is, what about pressure situation in the left portal vein before and after? So we do this, we check the pressures before and whether occlusion of the shunt is increasing, leading to increased portal pressures, and to what extent, you know. Can we do the pressure measure? Asking, adding too many things. Three different stuff. We can do the pressure measurement here quick. Come out, then do the pressure measurement again after. It's a lot of. It's fine. Save it for. Because he's anyways getting. ए डिस्टिल वाटर नहीं तूने लोड किया है कॉइल? मुझे देखना था पहले करके फिर. ठीक है कॉइल डाल देंगे फिर सी. ओके स्कोप होल्ड. पकड़ो. Yes. Deploy a coil. छोड़ो. Yeah. Yeah, nice. Okay, leave it alone. Leave the hand, yeah. Fluoro? If? Okay. Yeah, I think so. No. Why 10? Give me bigger one. Yeah, I'm gonna go deeper. 12. Let's go intravaricial now. Forget it. Give me a 12, yeah. Yes. Seems more like an outflow there, huh? Okay, it's okay. And then give me 2 cc of glue and NS after that, okay? Okay. Yeah. Keep going, yes, good, very nice. Very good, very good, very good. Fluoro. Okay, good job. Now let's give a 2 cc of glue. Thank you. So what we're doing here is basically obliterating this gastric varices, because of shunt treatment will lead to increase in pressures. Yeah, please go ahead and have the NS ready. Yes, okay. Good, good job. Quick, 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 quick. Very good, good. NS. Okay, injecting. Quick, 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 quick. It's almost stuck. Thoda. All right, good. Pull out the scope for 2 coils. Yeah, we use 2 coils. Because we're going to use the coils for the shunt as well now. A combination of glue and the 2 coils. Okay, good. Suction bandana. Suction is turned off, so I need a suction. We've used 2 cc of glue. Either it's more like arbitrary numbers, which you. I think the coils were well placed, and I think following the glue, 2 cc is a good number, good amount of glue. You know, I mean, the coils are going to help in terms of being a scaffolding, and yeah. So we put coils in the in what appeared to be a penetrator, and then actually in the main varix. Nowadays I've moved towards putting more towards penetrators than only the. Are we good, guys? This is okay? Yeah.
So it's the largest one in subcoil, right?
Penetrator, no? No, so we put a penetrator. In the penetrator we put the coils. What you want to do is ideally the inflow, but I think there's a lot of question and debate about which to do. So that's the other separate thing. But basically we've got it in the penetrator, a coil, and then another coil in the sort of actual varix, and then we put glue in the varix. Now you see immediately after there's a lot of stasis of blood, right? So you can see the flow is completely changed. Look at this flow, right? So the flow has really gone down to less than 3 centimeters per second. There's a lot of stasis. It's very slow. I think the inflow which we can't identify. I believe that was the outflow. That's okay. The job's done in terms of addressing the varices with a very slow flow, and that's going to coagulate and clot off and stuff. So where is the oh, maybe there? Yeah, maybe there. Maybe I didn't see that before. Yeah, maybe this is the inflow into the varix. I think this is it, man. Yeah. So that was the outflow. This is the inflow, which I think I didn't see it before. Look at this. This is the outside the tract, penetrating the gastric wall, and that's the inflow into the varix. And then it goes the varix here, all of it, and then this is the outflow tract actually. So now ideally what we want to do is address the inflow tract. You know, I don't know what the hell is that, but yeah, I don't know. So it's region almost. Anyway, so yeah, this is the inflow actually. You know what? Now I'm seeing it properly, which I wasn't able to find earlier. But yeah, that's where it is. So it was a real movement on the counterclockwise direction, and right in front of the sort of, I think that's the spleen there. Yeah, that's the inflow, and that's the penetrator. Ideally, I would have. This is would have been my ideal location to go, but now it's already the flow is really slowed down.
It's crossing the layers.
Yeah. It's crossing the layers. Yeah. So that's the penetrator. Now, anyway, so going back to the penetrator, see how it behaves and where does it go. It's the flow going inside the penetrator. Yeah, it's coming from here. The splenic sort of spleen. That's the splenic hilum. The penetrator rises from there, goes here, goes in front, and now it's the turbulent flow, and boom, that's where it goes in. All right, so that's another issue. I mean, the flow has really gone down anyway in that whole circuit now, so I think it's fine. So step 1 is okay. I don't feel the need to do more. But if I had to do more, I would go again, penetrator which is bang on right there, and then address it from this side. We could put another coil in the penetrator over here, and that will be fantastic. Let me see if I want to do one over here. What do you guys think? Should we put or not? Now, for the main problem which brings in here is the shunt. Already the flow in the shunt is sort of getting a little turbulent. Well, yes, that's the shunt. So you have to target the shunt, but a suitable window and a suitable access point is very important. My concern is in this case, that was okay what we just did. That's not a big problem. See, the flow is so low in this circuit here. And it sort of arises. Did you guys, have they pulled up the scan in the system? I think they must have loaded a scan in the system, no? Can you pull up the packs for a moment? Okay, so anyway, so now this is the splenic sort of, let's see, yeah, splenic hilum here. These are a bunch of collaterals in front of the hilum. The shunt going all the way. This particular one on the right. Front of the liver, this location here. So I feel like going here. This is a nice location. It's the chances and the odds are we could lodge a nice coil here. But the problem is it's a massive, massive shunt. That is the concern I have.
I think it will be enough to close all of this, right?
Endoscopically, I mean, you can do a BTO. Yeah. For that big size they can do. But I'm trying to find another location.
They are using the same coil also.
Yeah, they may have other coils. I don't know. I don't know if they have bigger coils. But they use Parto. Put a plug and then close it and then, you know. So this is the other area which I think we could do. But again, it's very big. Twenty-one. This is the other location I was thinking, which was here. More straightish location. Yeah, maybe we go here, guys. Straight. कितने हैं 20 के? Now, we can do this one. This is the only one I thought which is very doable. 16. 20, but the problem is it has to coil. Yeah. Huh? They will float is my concern. No, 20, I mean, if it goes properly, I don't want it to open and just straighten out. It has to form a coil. Slowly you can pull it, push it. So let it coil. You push it fast, it may go, I mean, technically, in theory, it should coil. Try it out, I mean, it's not a big deal. What's the worst case scenario? Tell radiologist to do it. you know. Spleen.
Spleen is ignored.
What's that?
Spleen is ignored.
Yeah, it's a big spleen, man. It's a big spleen. The artery in front of us. Right, that's the artery, splenic artery. I mean, the other access point is right in front of the spleen, but I don't want to be too close to the spleen when I do this case, you know. So this is spleen. We go in, and this is the other part. You know, again, and then somewhere, let's see where, and then boom, that's where the shunt is. You see? So this is all the splenic hilum here, and then we turn, and that's where the shunt starts. And this whole thing is now a shunt, which then goes around and spleen, hilum, somewhere the shunt is going to start right there. And then there's one branch going this way. Again, into the spleen, shunt. 6 o'clock is the shunt, goes around here, near the pancreas here. Goes 6 o'clock. The artery is in front. Should we consider this portion? Maybe this portion. My little worry is I'm not too far from the spleen. That's my only concern. I don't know if it makes any difference. Technically, shunt is shunt, so it should not really make a difference. Yeah, I think again, now look at this here. 14 mm. It's not too bad here. And if I can get some pancreas to support me here, it may not be a bad idea to go through that portion. Yeah. Maybe, maybe go here. I'm going tangential as opposed to straight, if that helps. And this is the inflow into the, yeah, that's the vessel which is slow. Yeah, this is the shunt. So I think we can do this one. Either this or the previous one of the two options. 45. Yeah. No, I'm not talking pancreas. There's some tissue in front. I'm not. It's like this is pancreatic tissue here. So if I go here, I'm getting some pancreas support, but the artery is also there. That's one issue for me. Maybe here, maybe this one. I have a little bit of pancreas tissue to support. Yeah, if the artery wasn't here, this would not be a bad location where I'm seeing. Chalo, let's do this. Let's do it here. Guys, 20 mm coil. No, I want you to load now. Because this is 11, so it's a narrowest space. Narrow is good because I want it narrow. Ideally, at an edge would be better. At like sort of the. Just load it. Give me a 20 mm. Keep another 20 mm ready, and then 2 cc of glue. So narrowest point is where we want to go. So hopefully. Let's see. I don't know. Let's see. I think last we've had one wonderful deployment. In one case, the coil kept sort of going straight. Did not, coil in the way we would have liked it. So this is number 3. So we'll see how that goes. Okay. Where do you want to put in a little more? Okay. Yeah. Good. Let's see how that deploys. That's my main thing. I want it to coil and not just stay there. Yeah, that's great. I'm actually very happy. It seems to coil. Give me one more. Yes. Yeah, that's the problem that happens. It does not tend to sort of. I mean, it's a big coil, so, that's a real problem. But it's okay. It's a coil. Let's do one more. Wow, that was fast. Do you see how fast it went? Okay, one more 20 mm coil now. Give me 18 mm coil after that. I'm going to really pack it up. See, now it's looking even better than when it started. See, it's now made its 3 turns, which is great. So we can pack it up and then put enough glue that it stays there and occludes it. Will be good. We can always do another session probably. Partial is also fine in a way. Sometimes even the partial will do the job actually. You may not get 100% in every case also because of really massive shunts. In fact, our partial guide did better, I think, than the full closure. Yes, good job. Yeah. Yes, keep going. Nice. Yes. Slow and steady. Easy. It's okay. It's sort of okay. Give me 18 mm also. It tends to find its least resistance space. That's the other thing. This was a challenge last case as well, right? It went like sort of straight. So it did not exactly coil in as best as we would have liked. So this is number 2. Number 3 now. Do number 3rd now. And then give 2 cc of glue. Maybe 2.5 cc of glue. Put a little more glue than usual. I think this probably, I think this will be like a partial thing. Can't we use gel foam now? We won't be able to do gel foam now. Let me know once you reach. I'll change the orientation of the needle once you reach. Okay? Reaching? Okay, good. Now do. Let me hit the back wall. Yes, push. Same issue. Okay, good job. That's fine. You have one more 18? You have one more 18? Take it. Give me one more 18. More. Really packing it, man. You should.
It's not migrating, so it's great.
Yeah, I mean, confirming that, right? It's not migrating. It's sitting there. Have the glue ready after this. Okay. It's okay. Finish it off. It's fine, done. Okay, good. Good spider web. Glue now and then out. Oh, where does it go? On the right, huh? Did it go on the right? NS? Show me again. Put some NS again. Can't really get a view. Show me again a little bit of NS. Yeah. I hope so. I want it to go there. It's okay. Let's do glue. No, glue. I just have a lot of NS ready, huh? Okay. Wait. You know when? Okay. All right. Suction is off, huh? We will see. Yes, 100%. Yeah, what's this? क्या करूँ? अरे? पक्का, are we good? Suction on. Just put some water, huh? Flush it. Okay. This is what? 6 coils now? 4 here. Okay. Okay. Okay, let's see what has happened now with this. Some flow reduction. Come on, man. Something should have happened. Okay. That's the first one. Shekhar. Could I be Shekhar? Okay, let's go down. Spot. Yeah, there it is. 6 o'clock. Yeah, I mean, I don't see much going on there. It's okay. You have some. All of that is the addressed area. Yeah, yeah, that's what I'm going to do now. It's going to have some flow. See how much are we dealing with. Yeah, there's reduced flow there. Look at that. See? Yeah, so the location where we targeted looks good. Now the question is how it's going to behave in the other spaces. There's going to be some hematoma. Yes. It's all magnified as well. I'm at 4. So that's where it is. Now what I have to do is understand where the hell is it connecting. So that's all the action. Action leads to somewhere here. Now this is the proximal part, I believe. There could be I mean, obviously this is not going to stop immediately. There is a reduction of flow. Say it was 20 before, is now gone down to 10. Yeah. Shunt. This is the proximal part. But you see the turbulence of flow? Yeah, this is where we would have gone. But the flow is very turbulent. You see that? It's not the same as before. It's turbulent, it has reduced. I think I'm going to leave him alone with this and see how he does. Yeah, okay. That's that. Yeah, that's the only problem. Which one? Oh yeah, I don't know what that is. Yeah, I don't know what that is. Yeah, okay. That's a small hematoma. Fine. Yep, okay. All right, so let's see how things go with him, you know. Yeah, I just want to make sure he doesn't have a bigger problem than that. This is let's see.
Another session later on can show.
Huh?
Another session later on can show what is the situation.
Yeah.
Maybe reduce the time after this.
Yeah. It's this much hematoma. Yeah, I think we leave him alone right now, obviously. No more punctures. That's it. We're good. That area seems pretty good. Let's see what happens to the flow later. You know? ठीक है, ma'am. We are just pull out after this, ma'am. It is a huge pulsatile thing. Okay, fine. We'll come out now. It's a portal vein, but why is it? It's crazy. I should have. I didn't see the portal vein before, so we'll see. Okay. Okay. Thank you. we need to see how things pan out for him.